to the CONNECT Collaborator Interview Series, where we host 10-minute conversations with healthcare professionals and partners with the goal on encouraging deeper collaboration in the healthcare industry. Today's guests may look familiar. We brought back our colleague David Lee, the founder and chief collaboration officer at Health Collaboration Partners and executive director of Alliance for Health Implementation Science. David's organization, Health Collaboration Partners, helps healthcare nonprofits, startups, and biotechs by increasing funding support, optimizing multi-sector collaborations, and communicating scientific impact more effectively. One of David's most recent collaborations is with the Alliance for Health Implementation Science, which is looking to transform how patients can benefit from healthcare innovation. David, welcome back, and thanks for joining us again.
Hey, great to be a repeat guest. I really appreciate it. Great to see you.
Excellent. So David, I'm interested in learning more about the Alliance for Health Implementation Science. I think it goes by AHIS. Can you tell us a little bit more about what makes it so unique?
Sure. So the Alliance for Health Implementation Science, or AHIS, as you said, is a newly launched nonprofit organization really focused on the gaps in implementation science. So, this crazy statistic that it takes on average 17 years for a new therapy or care model to be put into routine clinical practice. So really the goal of the organization is to drive that innovation because obviously patients can't wait 17 years to potentially have access to the right care that they need, innovative therapies. And as we were looking at the landscape, especially here in the United States, there isn't any one organization focused on implementation science. Broadly, we have, nonprofit groups, industry partners that may be doing certain, projects in specific disease areas, but no one kind of looking at this overall. And then I think kind of the idea is, of course, you can't do implementation science across all disease. So really our goal is to now start to drill into some specific disease areas and, see what triggers we can help push over the edge to accelerate that work, if it might be policy change, education of healthcare professionals and consumers, whatever those gaps are and the reasons why there is this large time gap in, having access to some of these medicines and care models to make sure that, we can accelerate those. Because the other interesting thing that, someone I was talking to said was that, well, about the average patent life of a, new therapy is about 17 years. So to think if we can shrink even by 5 years, let's say, getting the right patients on the right therapies, we're going to really be able to drive patient outcomes much more rapidly.
And I think you've kind of alluded to already, but this increased shift in implementation science, why do you think it's so critical to patient outcomes and evidence-based practice? Since education and education models have been around for a long time.
So I've been in the osteoporosis space for about 12 years. And I had never thought before really, starting to scope out this organization, realizing that many of the gaps in osteoporosis patient outcomes really are due to implementation science gaps. And, there are multiple ones, I would say, both, from the educational side, both the, providers, healthcare professionals, and consumers don't prioritize it, don't see it as, or see it as something that's just a part of normal aging, nothing you can do about it. And then I would say even more so on kind of the policy and payer side, at least in the United States especially, there's a model, called a fracture liaison service that has, spread across the globe to make sure that patients after they have a fracture get screened, diagnosed, treated with osteoporosis if they have it. And I would say the reimbursement model here in the US is very challenging in that it's hard to start these programs just from the purely financial perspective, to hire a coordinator to run these programs and then know that this program is actually going to lead to less fractures, which, if you look at it from a purely financial perspective, is lost revenue to the institution if they're in a kind of more fee-for-service as opposed to, value-based kind of payment model. So I think there's a lot that needs to be done, at the kind of top of the house, what we call top-down, in changing policies as well as education, which would be more bottom up. So I think we have opportunities in osteoporosis and lots of other diseases that we have these gaps, to accelerate the ability to get either, care pathways set up, get access to appropriate therapies. Here in the US, again, sometimes you've got to step through a couple of therapies before you get maybe the therapy that your physician would like you on, because of payer issues, other issues, related to access to therapy. So I think the more we can do to create some programs through AHIS that would have the idea as well as this would be a very multi-stakeholder effort, both at the project level as well as at the kind of organizational level. So we would have biopharma companies, leading clinicians, nonprofit groups, patients themselves, all kind of, creating these plans to see how we can work together across sectors to make a bigger impact than many of the individual stakeholders have been making on their own.
What do you see the opportunity for industry or their role to support these implementation science programs?
Yeah, so it's interesting. So there are some industry partners that actually have field-based staff that are focused on implementation science, or actually have programs that are driving some of this work, funding research, funding education. So I think more and more industry partners as well see this as an opportunity if they can help their customers figure out some of these challenges and to provide some tools to be able to better address some of these disease states. And in the case of back to osteoporosis, finding these post-fracture patients, but then also if there are mechanisms to find patients that maybe don't know that they have osteoporosis. And certainly a lot of the AI and machine learning, especially imaging companies that are coming to the fore, are now in osteoporosis, for instance, able to do very intelligent primary prevention because they can maybe find an X-ray or CT scan that was done a couple years ago and can actually measure that bone mineral density instead of waiting in this fracture liaison model. You don't capture the patient until they've had a fracture. So I think a lot of the technological advances is also going to lead to being able to much more rapidly address chronic disease, because we will have this ability to find these patients that right now is a little bit harder in the kind of older school system that a lot of medicine still sits within.
And you recently shared the JAMA article by Rita Rubin on the goal of implementation sciences really speeding up evidence changes in practice. What do you think is one program you've seen or you're aware of that's really demonstrating this need for implementation science and its effectiveness?
Yeah, so Amgen actually has a program called the Lattice Consortium, which is focused on cardiovascular disease. And a lot of the work and funding that is being supported through that program is really starting to get our heads around what those kind of gaps or levers that we need to pull to be able to get, in this case, more patients first screen for cholesterol, and then of course if they might need a therapy, looking at what interventions they might need to be able to address that, because obviously cardiovascular disease has a lot of impact beyond even cardiovascular disease in lots of comorbidities, and I would say for many other chronic diseases is in a very similar place. And there are in the US and even globally academic institutions, the National Institutes of Health, lots of work happening around implementation science. So I think the time is ripe to have a group like AHIS existing to be able to kind of pull all this together. And I think our strategy in the short term is to start to develop a couple of key initiatives. So we're starting to scope out initiatives in asthma, rare diseases, looking at cardiovascular and bone health as well as places that we could start. And then I think once we can really start to implement some of those projects, we'll then be able to kind of build the larger coalition that would be more like a membership program that would have all the stakeholders at the table. And I think that would be the place we'd probably solve some of those larger implementation science issues that kind of cross-cut various disease states.
You touched on it a little bit, but what do you really look forward to AHIS accomplishing in the next 12 to 18 months?
Yeah, I think for me it's launching and implementing the couple of first initiatives, and of course getting readouts and really seeing from a KPI perspective and patient outcomes perspective how we can start to kind of move the bar on those diseases. And I think then hopefully the the enthusiasm will start to snowball. And then, given that we're still in kind of startup mode, just have to kind of measure how much we can do with the small staff and small group of folks. But I think as we build our programs and can build our infrastructure and our capabilities, that's going to really, give us a good opportunity to, start to really make an impact around implementation science.
Once again, can you tell us where the best place for people to connect with you?
Sure, yeah. So the AHIS website is www.ahis.org. And that's the best place, to learn more about AHIS, what we're doing. With my other hat, my Health Collaboration Partners hat, you can go to healthcollaborationpartners.com. Certainly can find me on LinkedIn. I guess the other thing I wanted to mention back to AHIS is we did have a kind of a launch salon investment event in July here in the Los Angeles area where I'm based and where a lot of the folks that are working on AHIS is based. And I guess the one thing that was a takeaway for me was there were people that came to this event that maybe didn't know much about implementation science or weren't even necessarily in the healthcare field. And the emotional stories that came out as people started to reflect on themselves, their family members, parents that had bad health outcomes because of implementation science gaps, it was really kind of I guess validating as well as very rewarding to see that people were starting to see how a group like AHIS could really make an impact. So I wanted to make sure that I got that in before we concluded, because it was really really impactful to me.
Well, that's fantastic, David. Thank you for your time today.
Thank you. All right. Have a good day.